I'm a consultant in the London office, and I lead the Pride team for the London office, which is Pride at ZS is our LGBTQ group for ZS, for those who don't know. And I think it's really great that we have people joining from all over ZS. We have people from the US, from the UK and Europe, and also from India. And so we really wanted to make this a global conversation. I think we also might have some clients on the line, just for everyone's awareness as well. So I guess some context behind this panel discussion. So in honor of World AIDS Day, which was on December 1st this year, we at the Pride at ZS team in Europe wanted to put together a panel discussion to educate the ZS community about HIV and AIDS and inspire sort of ZSers to work on projects in this space. So given HIV/AIDS disproportionately affects members of the LGBTQ community, we thought it was an important platform to bring awareness to the disease. So it's also an area where you have lots of patient and community advocacy that's had a huge impact, both on responses by governments, pharmaceutical companies, donors, and NGOs. And so with this year's theme for World AIDS Day being let communities lead, what the Pride team wanted to do was we wanted to invite some members of the NGO community who we know to sort of talk to us about their work. And so with this in mind, I think it'd be great if we have our panelists introduce themselves to us. So I guess if we could start with Jalpa, that would be great. So can you tell us a bit about sort of your connection to HIV and AIDS and what you do and what your organization does in this space?
For sure. Thank you so much, Jacob, and to the ZS team to invite me for this discussion today. And it's a very important one and very close to our hearts. So I'm happy to be there. So thank you very much. My name is Jalpa Thakur, and I am a doctor by education. And further to that, I have a master's degree in public health. I've been working in the public health space for the past 10 years now, and I started working with the tuberculosis program in India, followed by the HIV/AIDS program now since the past 5 to 6 years. What I specialize in specifically from my end, I love to work, on innovations and the programs that have not yet been implemented through the national program in India, but have evidences across. So what I really do is innovate, pilot, and then try and scale it up and sustain it. One of the examples being digital innovations for HIV/AIDS, specifically to reach to the population who are there online on the internet. So India particularly does not have any programs of that. Besides that, I work in the public-private partnership and, of course, very close to the national government here in India, which is the National AIDS Control Organization. And all the work that I do and my organization does is absolutely in integration with the government of India. So I belong to the organization called Johns Hopkins University School of Medicine. My office, the main office is in Baltimore, but I work out of India and Delhi. We are a recipient of a USAID grant under the PEPFAR funding to implement innovations in India for the HIV/AIDS program alongside the government of India. And the project name is called as Accelerate, and we work across, I think we'll be discussing more about that, but we work across the entire program of HIV/AIDS, from prevention to testing to treatment, particularly in a few states of India that has a higher prevalence than the national average for HIV/AIDS. So I think I'll stop here and over to you, Jacob. Thanks.
Thank you so much, Jalpa. I'll hand it over to Pascal to tell us a bit about himself.
Thank you, Jacob. Can you hear me?
Yes, yes.
Great. So good afternoon, good morning, good evening, everyone, and thank you so much for inviting me today. I'm thrilled to be part of this discussion, and I look forward to also hearing from you and your comments and your questions. So a little bit about myself. Maybe it might be sound very personal, but I was a teenager when the HIV pandemic was at its peak, so I felt very touched by what was happening and also connected with the populations most affected. by HIV, and I really always wanted to do something about it, but I didn't know exactly what. And I actually started my professional career in the humanitarian sector. I worked in different countries, working for different organizations, including the International Committee of the Red Cross. And then I had the opportunity to join an NGO that was focused on HIV, on the work of HIV, and there I worked on the implementation of a capacity strengthening program for advocates and clinicians from around the world, and that's where my let's say passion started, and I had then the opportunity to move to Myanmar, where I started working for UNAIDS. And I was also working on the implementation of a project, really trying to provide HIV services for key populations such as sex workers, people who inject drugs, and also gay men and other men who have sex with men. I'm now based in Geneva in the Global Center, and I've been, focusing my work on urban HIV responses. So it's a niche within the HIV response, but it's because we believe that city authorities can take the lead in their response to HIV at local level. So we're trying to push for that and to provide as much support as possible. And I will actually start a new position soon, and I will be working more around advocacy and influencing to really keep HIV on the agenda. We know it's more and more complicated with competing priorities at national and international level, but we talked about the last mile so much, and it's there, and so that's why we need to keep pushing, and we need to keep the investment in terms of like financial investment, but also any other resources. Just to say a few words about UNAIDS. So UNAIDS is a joint program of the United Nations. So we work with 11, we call them co-sponsors, such as WHO or UNICEF. And we are the only UN entity that has civil society representation at its governing body. We have offices in more than 70 countries where we support government, civil society, and communities to accelerate the response and also build enabling environment. So we're also quite known for the strategic information that we provide, and it provides data to better understand the state of the epidemic and where the gaps are at local, national, regional, and global level. And we are also kind of, proud. We have that, flag to say that, we fight for the human rights of people living with HIV and also for the communities most affected by HIV. We hope that we can give them a voice, and not only a voice, but a say in the decisions that are made at country and also at international level. And yeah, so we're very proud of that, and that's what we're also trying to push for. And I'll stop here. Thank you.
No, thank you so much, Pascal. And then Maggie, I'll hand it over to you.
Sure. Thanks so much. It's wonderful to meet everyone, and thank you for Zias for inviting me to this panel. I work for San Francisco AIDS Foundation, and we are a direct service agency here in the U.S. Healthcare is not free to everybody, and we provide sexual health, mental health, housing assistance. Housing is also very expensive here. And more we focus on people who are injection drug users. And I work on the world's best program, I think, certainly the best job for me. I specifically work on a fundraising event. It's called AIDS Life Cycle, and we've been doing this bike ride across California. It is a 7-day event, and anyone on this call is welcome to join, ride their bikes across California. It's a 7-day event, 545 miles. It is difficult, but it's an amazing challenge. So each year we have about 3,000 people participating, 2,500 on bikes. Everyone else is volunteering to support the event. We are a fundraising event. One of the things I love about it is we are raising funds not only for health services in San Francisco, but we partner with the Los Angeles LGBT Center. So half of my team works in Los Angeles. Similar to Pascal, from a young age, I knew that HIV was a very important thing in my life. I grew up outside of New York City, and then I moved to Montreal as a student and found my way to a community care organization. So quickly, I just knew I had to get involved. So I am thrilled to be here today. And I work specifically, I work in both community engagement and also specifically with corporate engagement.
Amazing. And then I don't know if Sham is on the line or not. If you're there, please give an introduction. If not, then we can sort of move on to the first topic of conversation. I don't think he is, so I think let's move on. So I wanted to pick up a little bit on something that Pascal said about sort of the last mile in HIV/AIDS. I know that when I was doing a bit of research for this panel, we talk about sort of ending the AIDS pandemic by 2030 as a UN goal. And like in the news recently, you also see certain countries making statements, like, for example, Australia making a statement saying they're one of the first countries on track to ending the HIV/AIDS pandemic. I guess given that we have an epidemiologist on the line, it would be great, Jalpa, if you could talk to us a little bit about sort of what we actually mean with these types of statements, and a little bit about sort of the different cascades in treatment and how that connects to the goals of ending HIV and AIDS.
Thank you so much. Yeah, I'd love to talk a little bit about that, and I'm sure Pascal can throw a lot of more light on that as well. So when we talk about the targets for HIV/AIDS, and when we talk about elimination of HIV/AIDS in globally in 2030, UNAIDS, I think since 1978, right, has been setting goals and targets for countries specific and at the global level again, to achieve those targets across the cascade. Now, let me talk about the entire cascade first. So we talk about 95, 95, 95 right now. It was earlier 85, 85, then became 1990, and so on and so forth. So right now we are at 95, 95 up till 2025, and then the goal is to eliminate by 30. So what does this really mean? So we talk about the first 95, that is the first pillar of the cascade. The second 95 is the second pillar, and the third pillar is the third 95. So the first 95, what really means is that all those, all those who are living with HIV should know their status. So what that means for the program, what that means for the country is really that we need to have programs for outreach activities, for finding the people who are vulnerable out there and who need to know their status. So know their status as a campaign was very, very important early on in the program, and it still continues to be, because it has its weight and impact on the second and the third 95 continuously. And before I go to more explanation, I would also want to talk about why the cascade is important and how UNAIDS has made sure that the 395 has braided always together, because of course, like prevention, testing, treatment, these cannot work in silos, right? It has, every pillar has implications on each other. So if you're finding more people who are living with HIV, they are going to need tests, and they are going to need laboratory supports for confirmation, and they are going to need the treatment program to come on treatment early, and then they're going to need a program to retain them on treatment, because we know that HIV is a lifelong disease and we need to be on treatment forever. So retention again is very important, and to retain somebody on treatment for a long time, we need some monitoring parameters, which really means measuring the viral load. So these 395s are very much integrated together, and I think HIV/AIDS is the first program all over the world to have such a continuum of care that talks about the entire cascade together. Because I've worked in TB, and I know TB is now starting to follow this continuum of care where HIV/AIDS had this so many years back. So that's the whole, I think, in very short, the history about why the continuum of care is so important. And the first 95, like I said, it mainly talks about outreach activities. It mainly talks about testing activities so that we can go out there, find the right communities, find the right people, find the vulnerable and at-risk population, and bring them to the testing centers or provide testing for HIV to them. So the first step is called screening, and the second step is called confirmatory testing, right? Once the person is confirmed that they have HIV infection and are diagnosed as HIV positive, the immediate next step is rapid ART initiation. ART is nothing but antiretroviral treatment, which is the antiviral drugs that are used to manage the HIV infection in the body and prevent the HIV virus to escalate to a level that leads to further co-infections, and which basically leads to the AIDS syndrome and then further mortality. So at least by now in most of the countries, barring some countries in Africa, we have been able to manage to, not to prevent co-infections, and the mortality rate has come down much lesser than what it was before. So the second 95 basically means that once we know that a person is diagnosed of HIV, should have access to treatment at the nearest, like most accessible way, most affordable way, and the most sustainable way, because we have to take that treatment forever. And the third 95 is basically about retaining the person on treatment and ensuring the viral load, which is the HIV virus count in the body, is at a certain level, which is not detectable in the blood count, which means that one cannot transmit the infection to the other, even if you're still living with HIV. Of course, your HIV test will always remain positive. Sometimes it comes negative if the viral load is too low, but that doesn't mean that there is no virus. The virus is not detectable, and the one who is living with HIV cannot transmit the infection to the other person, which means we are ensuring prevention through treatment. And so the U is equal to U we call it, the treatment is the new prevention, right? So undetectable viral load is equal to untransmittable HIV infection. And I think that's become the prime, you were talking about the treatment target. So that's become the prime importance, I think, especially in India and many other countries, to achieve, because by that we can achieve prevent a lot of new infections from happening, right? And I wanted to also talk a little bit about when we are testing, when we are providing prevention and testing services, there were many innovative services that came into being. I think of late, we are working on the HIV self-testing kits in many countries to reach the population who cannot reach the facilities. A lot of countries have already implemented pre-exposure prophylaxis, which is taking a pill. Especially for those who are at very high risk of contacting HIV, they can take the pre-exposure prophylaxis pill and prevent the HIV infection in spite of coming in contact with the person living with HIV, right? So these innovations are helping us prevent new infections globally, and I think all of the countries are working towards it. I can talk a little bit more about India, maybe in the subsequent sections. But these innovations become extremely important, and U is equal to U, that is providing treatment to all and retaining them on treatment for a longer time becomes one of the prime importance for preventing new infections and transmission. Thanks.
Oh, thank you, Jalpa. It's really important to see the connection between sort of both like the diagnosis all the way through sort of the treatment. And so I pulled up some numbers that look at sort of how different countries are doing. And so a lot of the, I guess, countries that ZSers are from are high-income countries, India being a middle-income country. But I think something that was quite surprising in a really good way was like Botswana, which is arguably a low-income country with a very high HIV prevalence, is actually doing quite well with these targets. And I know UNAIDS works in Botswana. So I was wondering, Pascal, could you tell us a little bit about sort of what is going really well in Botswana and like what are they getting right as a country? Oh, Pascal, you're on mute.
Yes, thank you. So thanks for the question, and thank you, Shalpa, for the very good, overview and explanation on the 95, 95, 95. And yes, you look at the HIV prevalence in Botswana, and if you compare it to, England, for example, it has, like, you can compare. And actually, it's much lower than what it was in the early 2000s, because in Botswana, early 2000, the HIV prevalence was close to 35%. So they've come from a long way to reach actually the 95, 95, 95 and beyond, actually, because they are at 98 for the second 95 and 98 for the third one. So it's very impressive, and it's actually something that we highlighted this year at UNAIDS, just to show that some countries are making very good progress, and it's not only Botswana in the region, but Eswatini, Rwanda, Tanzania, and also Zimbabwe. They've reached the 95, 95, 95 already. So we're very proud of them, and we will keep pushing. I just wanted to give a little bit of context, about Botswana. Just to say, we know the HIV prevalence now, how it was in the early 2000s, but we can also talk about the AIDS-related death, which dropped by 72% between 2002 and 2020, which is also extremely impressive. The number of new infections was reduced by 61% over the same period, so it's also very impressive. And then actually Botswana managed to cut child transmission rates to only 1.7%, and it was at 9% 10 years earlier. So it's very impressive, and you may wonder, what did they do, and why they are so good in accelerating the response, and some other countries are not. And it's obviously multifactorial, but we know that what's extremely important and what's key is to have a sustained political leadership and commitment from the highest level. If you have, the president behind your HIV response, it makes a very big difference. To have strong domestic and international investment. So it's, that includes also PEPFAR and the Global Fund, to work really with the scientists and to apply the science, and that Botswana, was a champion in that, to create partnerships with as many allies and partners as possible. And we mentioned it earlier, to engage civil society and communities, and actually not only engage, but to have them from the very beginning of the design of what you are going to do for your response until the end of the program, for example, and also to have evidence-based guidelines and policies. And I just wanted to be a bit more specific about what Botswana has done, which were extremely successful. And so Botswana, for example, was the first African country to offer ART to their citizens for free. And they did that by partnering with there was a partnership between the government and the Bill and Melinda Gates Foundation, so private-public collaboration, and also with Merck. They donated the drugs. And it was also supported by PEPFAR and Global Fund, as I mentioned earlier. So that was, a multi-partner collaboration, which was extremely successful to put people on EART. Then the policies, evidence-based policies, they paid off in Botswana with, as I mentioned earlier, a reduction in the number of new infections, and also in the number of AIDS-related deaths. And it's hard to measure, what is the impact. But for example, at some point in Botswana, a couple of years ago, there was they decided to decriminalize same-sex relationships, and so that helped, to get people from that community to health services and to get tested, to get the treatment if they were living with HIV. So that makes a big difference, because if you work on the environment, then it has an impact on your response. Then in terms, going back to the vertical transmission rate, it was also a policy that was to actually test and treat women, and actually even before they became pregnant. So, and there was a strong partnership with other health programs, so integration with, for example, sexual and reproductive health services, and other services, to make sure that it was available everywhere. And that patients would not only be screened for HIV, but for other viruses and diseases. Then in 2019, what the government of Botswana did was to extend free HIV treatment to non-resident. And that was a gap, with the data, they saw that there was a gap in, having non-resident also covered by HIV services. So they made it free, and that made a big difference in the response. Botswana also, and I don't work for the government of Botswana, but it's really to show you, everything they've done to really accelerate the response. But they did, and they do receive funding from international donors, but they also invest a lot of their own funding into the response, and that actually has an impact also on the sustainability of the response, which is very, very important. I mean, it's just a few examples that, if we put them together, it has a big impact. Just to summarize, the domestic commitment, the policy initiatives, the non-criminalization of key populations, the engagement of civil society, and also, and very importantly, to follow the science and apply the science. And I'll stop here.
Well, thank you, Pascal. It's really interesting to see all these different elements just working together to bring the success to Botswana. I think when we look at the numbers, I was a bit surprised that the US numbers were actually so low. I guess, Maggie, could you talk to us a little bit about some of the challenges the communities you work with face in San Francisco?
Sure. Thanks so much. And I'm happy to speak. I'm most comfortable speaking about the communities in San Francisco as well as Los Angeles. There are differences across the United States. So I'll speak specifically to California. What we know and what we see in terms of numbers, in terms of new infection rates, numbers of folks who have achieved viral suppression, who access to care, is one of the biggest factors is racism. The folks who we see are at greatest risk and receiving less care, accessing less services are Black and Latino men and transgender women. Typically, there is an overlap where we see more of the transgender women who are Black and Latino, and often are engaged in sex work because that's the only kind of work they can do. And racism is very complex. There are many layers. So I'll speak to a few of them and what we're doing about them, what we're trying our best to do. And really, we are focusing our services and programs around the communities who are at greatest risk and underserved. One of them is, is proximity to services. If you have a lower income, simply getting across the cities to go into one of our clinics has a cost. It costs money to get there. The other big issue is if you're a Black man who has sex with men, often less likely to be out about your sexual orientation due to cultural factors. And again, maybe some some risk of violence in your neighborhood, if you walk in the door and all of the images, all of the posters, and this comes back to us at the organizational level, as well as where life science and pharma companies may be traditionally focusing their advertising, if you don't see yourself reflected, if you are not greeted by somebody who speaks Spanish or somebody who may look like you, that is a huge issue. So we are significantly investing in and making efforts to bring in folks, and often train folks who may not have had the opportunity to have as much formal education, to be counselors, to be people who actually lead our programs, right? We cannot have all white 50-year-old women, men who are leading these programs. It's very important that they're led by members of the community. So that really is what we see, is that the racial health injustice is the biggest factor. And so that's really what we see in the cities, and that is the work we need to do.
Oh, thank you, Maggie. And Jalpa, thinking about sort of some of the states that you run programs in, what are some of the key challenges that people in those communities face? Do they overlap with some of the challenges that Maggie spoke to as well?
No, absolutely. But more than the racial discrimination here, it's about, I think, need to understand that the communities are in the center of planning the entire program in India. And also wanted to focus that the entire funding for the HIV/AIDS program, 96% of the funding comes from the central government of India. So I think the country has done a lot to bring the communities to the center, but I guess still the major challenge remains speaking the language of the community and being absolutely friendly with the community. So we do have programs called as targeted intervention programs in India, which are specifically to catering to the key population. So there's a targeted intervention NGO for the sex workers. There is a TI NGO for the men who have sex with men, for the injecting drug users, for the truckers and the migrants, and for the transgender population. So that was initially designed to cater to the insecurities, the challenges, the confidentiality, the stigma, and the discrimination that came along with the community. However, that is now not enough, because we are meeting the same people again. There is a young population who are at very, very high risk, who are getting infected, because like Pascal was saying, in India, the new infection rate had decreased to 80% in 2020, and now it has plateaued, right? So which means that we are not able to do much to reduce the new infections, and there are people who are contacting newer infections, and the concentration of the infection is still amongst the key population, that is the sex workers, men who have sex with men, the injecting drug users, the transgender populations, and to the great extent migrant population in India. There's a lot of migration happening between the states in India for work opportunities, because some states in India are financially doing very well and have opportunities for work, and some are not. And the trucker population, because we have a lot of factories here and a lot of goods coming in and going between the states, there is a lot of trucker population that travels for months together. So the concentration of the epidemic is amongst the key population, as we know, in India as well. And the major challenge is, I think, with respect to prevention and outreach, it is about reaching the unreached and the hidden population, who we see are now the youth, which is below 28 years of age. And it's becoming increasingly difficult for India to find out programs to reach that. And I want to also say one more thing, because I've been working specifically for this a lot. We need to understand now that just taking HIV/AIDS services to the youth and to the highest population is not going to be enough. There is more to them. There is more to that. And this, just providing a testing and a treatment and diagnosis and all of that and doctor is not enough for the youth. So we need to go to them and provide a more generic response as compared to what was happening earlier, that there were just HIV/AIDS clinics and treatment centers. But now there's a need to open it up, to give them services for mental health, to give them services for de-addiction, to give them services for sexual and reproductive health in general, general medical checkup and awareness about those diseases, providing opportunities for education, taking care of their vulnerabilities. So I think this is what it is. We need to recognize the need of the key population that is now emerging, and then devise programs. So from the outreach perspective, that, and like I said, the use of dating applications, right, and the use of internet to solicit partners, sexual partners, casual partners, dating partners, it's become the most dominant factor here in India, which it was not earlier. Earlier, the solicitation used to happen at physical sites, at the brothels, at the, unfortunately, at the public toilets in India, especially for the sex workers and the transgender community. But now it's changed. Now nobody's seen in brothels. Now nobody's seen in the public toilets. Somebody rents a house, there are hotels, there are lodges where the sex work happens. So, and everything is online. And we in India we have not really geared up to reach them through the online platforms. But our program specifically, we are working on the platform called as SafeZindagi.in, specifically for those who are there on dating apps, especially like Grindr, Blued, Planet Romeo, Tinder, etc. The second thing is about the treatment and the viral load. So like I said, we have the funding to provide free HIV/AIDS treatment to all those who are living with HIV and those who seek treatment in the public sector. For private sector, it's completely out of pocket, but for public sector, it's all funded by the government. However, there is always a demand and a supply issue, and to have the logistics and supply chain for a country as large as India has been extremely challenging. And so we are always short of drugs. We are always running short of treatment. But that doesn't mean that people are non-treatment. It just breaks the rhythm. It breaks the multi-month dispensation cycle. So that has its own challenges. And the third part is the availability of viral load testing. Right. So we in India started the viral load testing only a few years back in 2018. Before that, we didn't have the viral load machines and the cartridges. And that still remains an issue. There's always a shortage. So we are not able to monitor if the person is going into failure, the treatment is successful, and that remains. So there are challenges across the cascade. But I would say since our first 95 is the poorest, the biggest challenge is reaching the unreached and the hidden population.
Amazing. When we think about sort of the theme for World AIDS Day, let communities lead, I guess Pascal, as our UNAIDS representative, what does that mean exactly? And sort of what are some of the things that different countries are doing to really sort of bring communities to the forefront of the response?
Yes. Yes. Okay, I'm not on mute. Good. So thanks, Jacob. Yes, so this year's theme for World AIDS Day was let the communities lead. It's not new, actually. We've been pushing for that for many, many years because we know this is the way forward. As mentioned by Jelpa, if we want to reach those who are difficult to reach, and now we are, I guess, at that stage of the epidemic where, with the general population, we're getting there in most countries, but we still have difficulties in reaching the most vulnerable populations, the key populations, and the key populations who hide because they are criminalized. And if we talk about drug use or sex work or gay men and other men who have sex with men, they will not reach health services if they know that they can put themselves in danger. So that's why, we think that, the way forward is really for the communities to be free to be who they are, and then lead the response at country level. So there are a few things that, we highlighted during this World AIDS Day. And first of all, it's the community-led service delivery. So we want, the communities to deliver services and services that are accessible to all, that are grounded in people's needs, and also, as I said, able to reach the most marginalized people and groups, and that's key. And we mentioned it already, but communities know what is good for communities, and communities know what needs to be done. So we need to give them the keys. And in many countries, governments are reluctant to actually let communities do testing, for example, or do initiation, for example, because they want to keep that under the control. So that's what we're trying to push. To have more effective programs for HIV prevention, testing, and treatment as well. Then there is the community-led monitoring part, because we are also trying to strengthen that, because we know that the data coming from the communities is extremely helpful. It is extremely valuable because it enables us to understand where the needs are and where the gaps are and how to adapt the responses. So to have, it's called CLM, community-led monitoring. And it's basically having the communities on the ground, communities of people living with HIV and key populations, trying basically collecting data and analyzing the data and then sharing that data, so then we can be aware of what it is. And I don't know, maybe some of you are aware of a tool that is called People Living with HIV Stigma Index. We're now at 2.0, and it's something that is very critical in terms of data to addressing barriers in terms of stigma and discrimination that some people may feel when they go and reach out for HIV, for health services. And then the last thing that I wanted to highlight was the community-led advocacy. And so we want, people living with HIV and key population-led organization to be around the table, to be with decision makers, to shape the policies, to have a voice and be able to say, this is not what we need. This is actually what we need is this, and that decision makers listen and take notes and adapt their programs. It actually, it's a virtuous circle, kind of, because it brings structural changes, and it has, bigger positive influences on policy, and also in terms of, how people feel about health services in general, and they will more easily access them. So that's, what we're trying to push. And I mean, also, many of you knows, I'm sure, is nothing about us without us, which is, the motto of what we're pushing for communities to be heard and to lead the response.
Thank you, Pascal. Next question will be for Maggie. So Pascal mentioned sort of some of the challenges with working around stigma and with key populations, and you talked about some of the challenges earlier that San Francisco and LA face with specific communities. How are some of the programs that you're funding and delivering, sort of letting communities lead and bringing that sort of into what you're doing?
Sure. Thanks very much. So one of the important reasons we work on this event, for instance, AIDS Life Cycle, is that for our agency in San Francisco, government funding is only going to cover about 80% of our annual operational revenue, or excuse me, expense. It's still morning for me. Sorry, I haven't had coffee. So it's incredibly important that we receive funds from great companies, from fundraising events, be they 7-day bike rides, or this weekend we have a Christmas-themed holiday fun run called Santa Skivvies. So if anyone wants to fly over and do a fun run, typically in holiday-themed underwear and sneakers, these are examples of how we can develop programs that raise funds that are fun and that reflect our community, right? Every event does not have to be a gala. Every source of external funding does not have to be a grant, although we do love those. And other examples of how how great companies are helping us is we really, really have had to rapidly expand our services to support trans and the non-binary community. And we've had to develop the programs and the elements of programming faster than other areas in the United States, because San Francisco is different, Los Angeles is different. And in the 9 years that I've been working for the foundation, what I've seen is we've gone beyond having a once weekly support space to now being able to have a mental health counselor come in each week and offer one-on-one counseling as needed, as well as group support. We're able to listen to the great women and non-binary folks who come regularly to what they need. They need help getting out on the town because they are targeted. They don't feel comfortable showing up as their true selves. But when they have a chance to go out to a theater, to have great clothes and to look really good. I mean, we even have a company that is sponsoring a Botox clinic for either them or for other folks who want to pay, maybe so a client can get facial rejuvenation type treatments. I mean, these are things that are, I think, really important. And these are examples of things that are not your typical come in for an HIV test type services.
It's really interesting to hear about how, I guess, some of the more holistic approach to health is both happening sort of in San Francisco and LA, but also how, Jalpa, you mentioned that you were trying to bring some of those types of services, maybe not Botox, but some of the more mental health services to some of the communities you work in. Jalpa, could you talk a little bit about some other sort of ways that you're putting communities at the forefront of your response?
Yeah, absolutely. So like since the inception of the program in India, like Pascal said, India follows the UNAIDS guidelines very strictly. So the communities have been at the forefront for the program. So typically, to begin with, at the simplest level, at the government level, in the central government, we have technical resource groups, and in each, for prevention, for testing, for treatment, and for any new program that has to be added to the HIV/AIDS functionality. Now, these technical resource groups are comprised of experts from community, from outside of the community, policymakers, implementers, donors, partners, collaterals, bilaterals, etc., right? Multilaterals. So communities always have a seat in these panels, which are very important because these resource groups actually write the guidelines that the country will follow over years together. So at the decision-making level, the communities are absolutely at the forefront. Second, at the implementation level, I was talking about the targeted interventions, right? So all the targeted interventions, they are basically CBOs or NGOs, mostly run by the community, and if not typically run or owned by the community, at least cadre of the resources, human resources that they would have, either counselors or outreach workers or peer counselors, always are from the community, because like Pascal said, the communities know what they want and they should decide what should come into the program, right? So most of the outreach workers and the peer counselors who would actually go out there and bring the community to take those services are always from the community, and otherwise the programs will never work and has never worked in the whenever there has been a deviation. Then this is at the implementation level. The third level, which is the monitoring level, again, taking cue from what Pascal said, India has been working on community-led monitoring systems and community system strengthening. So we have in the country now more than 10,000 community champions who are more like, the torch bearers of the different programs. And then they go and inspire more and more community to come in and become champions. And each and every program running at the district, to the town, to the city, to the state level are monitored by these community champions. So they go there. And there is there's a questionnaire or a survey kind of a thing for evaluation at each of these centers, which is called as community led monitoring tool. So at the end of a quarter or at the end of 6 months or something, there is an evaluation that happens by the community that whether the services were satisfactory in terms of stigma, in terms of confidentiality, in terms of operationality, technicality, everything. So that data goes back to the state government, and the state government analyzes and gives it to the central government, and the changes are brought about. This is on the books. It may not be happening in the exact same way, but at least there is, a guideline, data tools and analytical space for that. So in India, all the programs are always implemented by the community. In fact, I think the rainbow clinics in Thailand, which were the transgender run clinics, were a great example. And now in India also, we have transgender run clinics. There are 3 clinics in India right now that are run by the transgender community. The doctor is a transgender over there. The counselor is a transgender, the nurse is a transgender. We're very proud to say that those transgender doctors were then absorbed in the general medical system by the government to function as doctors in a civil hospital. So that was a great win. So I guess these are, and I think what I'm talking is like a very part of what's happening at the country level. But from policy to implementation to monitoring, community remains at the forefront.
Yeah, it's so interesting to hear about how such a complex system can then bring these community voices to the forefront of it. So it's really great. I think we have about 10 minutes left, and we wanted to open the floor up to questions, both from our Pride group and from the audience who's joining. I think one question that did come up was around sort of what can pharma, or what message can we bring back to like the clients we work with in pharma about sort of what they can do when we think about communities and community-led responses in such a complex sort of network of stakeholders. So if anyone wants to tackle that. Maggie, I know that you mentioned something about this earlier. Can I hand this one to you?
Okay, sure. Maybe I can start, and maybe it's a great space for folks who have joined this call. Might have some experiences or questions, or perspectives that are different from the ones we're presenting. Again, I'm going to come back to funding. It's huge for us. Again, if we don't on our side have sources of funding that are non-governmental, we cannot run our programs and services fully staffed. We have areas, I didn't have a chance to speak to this, but similar to Pascal and Jalpa, injection drug use is one of the biggest issues we have in San Francisco. It is the most stigmatized area of HIV, and it's really difficult. We do not have all the answers. It's really difficult. There is a lot of stigma, discomfort around talking about drug use. And so I think that's an area where we could really partner more with companies on how do we get messages across. Hepatitis C is a huge issue in the San Francisco community. There's a strong overlap between HIV and hepatitis C. So, continue to fund. I think additionally, bringing it, where are there opportunities to bring our clients, to invite, I say clients, that's incorrect. It's really members of the community who we serve into your organization in a way that does not tokenize them, in a way that truly respects their lived experience. And I think that is something very important. I think a lot of what this is relationship development. And I think, bringing that back to your employees, to the larger audience. So I think that's a very specific way that we can help. We can, help each other. And I think I would leave it there. There may be folks on this call who are already involved in this type of relationship.
Pascal or Jalpa, do you have anything to add to Maggie's response? There. Yep.
Sure, I can add a few bit to it. So, firstly, ZS has been working in India with Shyam's foundation, the NIST Foundation, specifically on the pre-exposure prophylaxis, and drawing a cue from there. What I wanted to really say is that, like Maggie said, I completely understand, completely agree. We cannot run the program in its fullest way with just the funding from the central government. So donors, funding agencies from the pharma companies becomes very important, especially when we want to bring in a newer, innovation or a newer drug, say for example, or newer laboratory diagnostic technique, say for example, to set a pilot, to set an example, and then give a little momentum for the scale to the country and make a use case, bring in the cost effectiveness and the cost optimization analysis up till that level that the government, knows exactly what is the model and the strategy to scale it up, and how much is the funding and the resources required to scale it up. If it brings the right results and the outcomes. So I think up till that level, funding for newer innovations become important. If I talk about India particularly, I agree with Maggie completely. Injecting drug users remain a very, very mystical area, even in our country, specifically in a few regions in the north, where the epidemic of injecting drug users is very high. Accompanied by the hepatitis, because the route of transmission is the same for HIV and hepatitis both. The newer innovations I was talking about, and somebody in the our audiences have also put up this question. The pre-exposure prophylaxis drugs are absolutely not a part of the national program. And it's not available free of cost. It's at a very, very high cost, and the communities for sure cannot afford it at the cost at which it is available over the counter. So I think things like those, these are just a few examples. HIV self-testing, it's not a part of the national program, but it's very much a need of the population that we want to reach to, that we were talking about, the vulnerable, at-risk, unreached population. So especially for these innovations, I think it becomes extremely important for companies like you, and you are already doing it in India, to collaborate and bring in those evidences.
Well, thank you, Jalpa. Are there any more questions from the audience? If we have any, please put them in the chat. I think Jalpa just covered the question on PrEP in India. But if there's other questions, please let us know.
Just to say, Jacob, if I can,
Yep.
very briefly, because I fully agree with what Maggie and Jalpa were saying about, funding and financial support, and because, it's in the end, that's also what we need. But I also find important to say that, like farmers, for example, should also make sure that they listen to communities. And, they make space for them to say what they need and how they need it. And because in the end, the products that the pharma companies are producing are for the communities. And so, yeah, it's just if you want your product, also it's actually, I guess, a win-win situation, because if you want your product to be successful, it needs to work with the communities and what they need. So it's really from the very beginning of the process to always involve communities, and actually more and more, also because like needs change, and you need to have that constant dialogue between partners. So I think that's also very important.
Well, thank you, Pascal. We have a question from Sabrina. So she mentioned she picked up on sort of not tokenizing certain communities in sort of messaging. Can someone in the panel provide some scenario-based examples of what sort of good looks like versus what bad looks like in this, like in terms of tokenization versus honoring those communities?
And Jalpa, please share if you'd like to. I think one of the things that that can happen, and within our organization, it can happen. It happens, is that we may invite somebody to a one-off, right, to an event, and they become the speaker because we think, oh, we should have a speaker who is a young man of color, and it's a one-off. we don't mean to do it, but it's a one-off. They come in, they speak, the audience feels like, oh, okay, you know, we're diverse because we've had a speaker of color. And really what we need is ongoing relationship, not just with that individual person, but likely they are leaders within their communities. And I think that is an area that we can really do better. And that's the one example that immediately comes to mind. It's also important, for instance, that we help people in the community develop things like professional group speaking skills. That's one example, that we have programs to help people to enter the job force. Our street outreach program, for instance, in San Francisco, which is how we are able to reach people who use injection drugs, is also a job entry or a professional re-entry program, right? So we specifically invite people who, for different reasons, have not been able to work, and this is very important. I think this is an area where we do well. Where's the opportunity? Are we able to have a company help sponsor this program, provide a little more funding? And I do keep coming back to funding because typically companies have those resources available where we may know the specific needs, the tactical work that we can do with our community's input and leadership if we have more funding. And I work in fundraising, so that is my area of passion.
Awesome. So we're at time, but I just wanted to say thank you so much to Pascal, Maggie, and Jelka for joining us today. This has been, I think, a really, really insightful and educational panel for our ZS community and everyone on the call. So we really appreciate it. But thank you so much.
Thank you for having us.
Thank you. Thank you for the great questions. And I appreciate everyone being here. And thank you for the organizers from ZS, or as I know you in the US, ZS. It's really been a privilege to hear from other people who work around the world in this area.
Thank you so much. I think, and thank you for the nice words the audiences are saying. But thank you. It was great interacting with Maggie and Pascal and Jacob with you too. We'd love to continue this discussion anytime in the future. Thank you.